Good evening, everyone. Please rise to salute the flag. Welcome to the March meeting of the Revere Board of Health. My name is Neza Alwadi, board member. Join me tonight for the meeting is a board member, Dr. Greg Costanza. Also in attendance for tonight's meeting are City of Revere staff. Lauren Buck, Director of Public Health. Michael Wells, Director of Municipal Inspections, Health Agent. Paula Spilveda, Administrative Assistants. Tonight's agenda is as follows. Review and approve minutes from February 24, 2022. Public Health Communicable Monthly Report presented by Lauren Buck. Presentation from Regional Epidemiologist Anne-Marie Kissel. Vote on regulations of the keeping of the chickens licensing. Request for the beekeeping license from Damien DeMarco. Dr. Costanza, would you approve the minutes from February 24, 22?
Yes, I do.
I approve as well. At this state of the whole agenda, now I'm going to move to Lauren Bach for the Public Health Communicable Monthly Report.
Thank you, Neza. So for March 2022, there's not much to report in terms of communicable diseases. The one thing I want to highlight is our influenza cases. We had 17 confirmed influenza cases over the last month, which their age ranges ranged from 3 to 85 years old. This is pretty typical for influenza cases in terms of age range. And you know, I think in general, we experienced in an influenza season that was a little less severe, similar to 2021, similar to 2022, because again, a lot of the mask precautions that were in place really helped prevent not just COVID, but influenza. So I think there's lessons to be learned there. Other than that, we had 2 confirmed cases of hepatitis C and 2 foodborne illness, communicable diseases. And other than that, not much going on there. Other important notes in a CDC report, again, just updating you all on information that I get from the CDC every month. A CDC report released on March 18th, the 2021 National Youth Tobacco Survey was conducted among U.S. middle and high school students during the COVID-19 pandemic, and revealed that youth tobacco use remains a serious public health concern. About 2.55 million U.S. middle and high school students reported current use of a tobacco product in 2021. Interesting to note that the 2021 survey was conducted exclusively online, so the results are a little bit hard to compare to previous years. But again, the US FDA and CDC analyzed the data, which they do every year, and found that e-cigarettes were the most common tobacco product currently used among middle and high school students. This has been consistent for the last couple of years. Other data analysis revealed that disparities persist among subgroups. For example, current use of tobacco products was higher among students who identified as gay, lesbian, bisexual, or transgender. Use was also higher among students who had severe, moderate, or mild symptoms of psychological distress. You could also say, you know, a mental health concern. Additionally, non-Hispanic Black students reported the highest prevalence of current use of combustible tobacco products, something like a cigar, which is significant because combustible tobacco products are responsible for most of the significant death and disease from tobacco use in the US. So again, that's a recent report that was released. And then I'll move on to our COVID statistics. Again, as of March 2021, we have total confirmed cases, 21,834. Our total deceased, so the amount of Revere residents who have passed away from COVID, has actually decreased from last month, we have 178 confirmed deaths from COVID. The reason behind this is the state DPH recently revised their the classification system for those who have passed away from COVID to make it more refined and more consistent with other states and the national classifications. And therefore, our case count has been reformulated. Our 7-day case average, it was 4.3 on March 21st. Our 14-day positivity rate was 1.7%. That rate is consistent with what I saw come through this last week as well. So we're holding steady at about 1.7%. I think what we can expect from potentially what we're seeing in Western Europe is our positivity rate and our case counts might rise over the next couple of months. It's really hard to predict. I wish we had a really good way of predicting at this point 2 years in. But we have to use trends that we see elsewhere, and Western Europe is usually a good correlation to what we see here. So we potentially could see some rises over the next couple months. Any other updates from COVID about COVID will be presented to you by our regional epidemiologist. And just to give you a background, so Ann Kissel is our regional epidemiologist, which means she serves the communities of Revere, Chelsea, and Winthrop. She was brought on several months ago and has been working on our public health data and interpreting our public health data. And so she has a really interesting and informative presentation for you all about kind of the state of COVID, where we are, taking a deep breath in after these last 2 years, and kind of an overview of where we are. Thank you.
Thank you, Lauren. Next in tonight's agenda is presentation from Anne-Marie Kissel, a regional epidemiologist.
Thank you. Just one moment as I share my screen. Can you all see that okay?
Yeah, we can.
Okay, awesome. So welcome. My name is Ann Kissel, and I am the regional epidemiologist for the North Suffolk Public Health Collaborative. The position is contracted through the Metropolitan Area Planning Council, and as Lauren just mentioned, it serves Chelsea, Revere, and Winthrop. I've been working closely with Lauren, and she asked me to present to you some of the materials that I've been working on these past few months. All right, so I've put together a bit of an agenda for us tonight, in which we'll be talking a little bit about COVID-19 case incidence rates specific to Revere and vaccination updates specific to Revere as well. Also, transmission effectiveness of immunizations during the Omicron surge in Revere, and then also kind of pivoting a bit to speaking about the future of COVID and what that could potentially look like. So first, this is the weekly case incidence rate of new COVID-19 cases per 100,000 in Revere, Massachusetts. From the beginning of the pandemic, February 2nd of 2020 to March 19th of 2022. I hope that this provides a more helpful visual of COVID-19 cases in Revere throughout the entirety of the pandemic thus far. And I've also labeled some of the peaks here in the waves that we've experienced. So the first one being April 19th of 2020 to April 25th of 2020, right here in the beginning. And then we have a peak in the second peak, that being in January 3rd of 2021 to January 9th of 2021. And then our most recent peak being January 2nd of 2022, and then into January 8th of 2022, that last Omicron surge. All right, so next on the agenda is the vaccination updates for Revere residents. So this is a bar graph. The light blue bars indicate the percentage of folks who are fully vaccinated but not yet boosted among each age group. The dark blue indicates those who are boosted as of March 1st of this year. And the gold indicates the percentage of those who have been boosted since March 15th. Within that 2-week period from March 1st to March 15th, we've seen an increase in boosted individuals across all age groups, as well as the overall total amount in Revere, which is this last set of bar groups at the very end. So we've seen that increase except for ages 5 to 11, which is understandable considering that vaccine eligibility has been delayed for this age group for the primary series. And then they also aren't eligible for the booster shot currently. Also linked here at the bottom is, which I can share my slides after with the Board of Health members, is where this data can be found on the mass.gov website. All right, so now we'll move a bit into the effectiveness of immunizations on transmission during the Omicron surge in Revere specifically. So on December 4th of 2021, the Omicron variant was first detected in Massachusetts. This chart demonstrates the effectiveness of COVID-19 booster throughout the surge of the Omicron variant from December 5th of 2021 to the peak of the wave in North Suffolk, which January 8th of 2022, so that 5-week period. In order to look at the effectiveness of boosters, first I pulled the cases from Maven during that 5-week period. Then I stratified them by municipalities, and then within those municipalities by vaccination status. I then calculated the risk of disease prevalence among each group of vaccination status. So for Revere specifically, we see that boosted individuals had 75% less risk of COVID-19 infection compared to fully vaccinated, not boosted individuals. And then boosted individuals had 79% less risk of COVID-19 infection compared to unvaccinated individuals. My goal for this data was to demonstrate the importance of COVID-19 booster on transmission within the community level data specific to North Suffolk municipalities. All right, so we're gonna pivot a bit to like the final portion of the presentation and discuss a bit about the future of COVID-19 and bringing into conversation this current dialogue around this move towards endemicity. So first, I just want to review some of the basics. As we know, COVID-19 began as an epidemic in Wuhan, China in December of 2019. An epidemic refers to an increase, often sudden, in the number of cases of a disease above what is normally expected in that population in that area. So specifically, I just want to point out, I know that this infographic points out an epidemic that's beginning in South America, but just for the sake of the infographic, it's just exemplifying the levels of disease, so please bear with me. So moving on to pandemic, then on March 11th of 2020, the World Health Organization declares a pandemic. After COVID-19 is detected in over 110 countries throughout the world, a pandemic refers to an epidemic that has spread over several countries and continents, usually affecting a large number of people. And then we move into this more recent introduction of the term of endemic into the COVID-19 conversation. An endemic means that there is an amount of a particular disease that is usually present in a community and referred to as the baseline or endemic level of that disease. Now, this level is not necessarily the desired level, which may be higher than 0, but rather the observed level of cases that remains consistent. So when I think of an endemic disease, I think of predictability, that there's a pattern of this disease and it follows a certain trend that we can predict within reason. So lately I've been asking myself, how do we learn from past respiratory pandemic diseases and how these diseases have run their course, and is it applicable to the current challenges that we now face with COVID-19? One of these past respiratory pandemic diseases was the 1918 influenza pandemic, which was caused by the H1N1 virus A. 1/3 of the world's population was infected. At least it's estimated that at least 50 million died worldwide. And in the United States specifically, 675,000 died. There were 3 different waves of illness during the pandemic, starting in March of 1918 and subsiding by the summer of 1919, as shown here in this graph. The pandemic peaked in the US during the second wave, and this wave was highly fatal, as we can see here. So in 1919, the pandemic subsides, the virus attenuates, and the strain continues to circulate seasonally for 38 years. Since 1918, the world has experienced 3 additional pandemics in 1957, in 1968, and in 2009, highlighted here in these yellow boxes. These subsequent pandemics were less severe and caused considerably less mortality than the 1918 pandemic. In the 2009 H1N1 virus is actually distantly related to the 1918 strain. However, the strain had evolved to become overall less fatal in terms of mortality, and it was eventually contained. So when thinking about these past pandemics and how they've played out, although there are benefits in understanding how viruses can evolve, like the 1918 strain, which became less fatal and continued to circulate seasonally decades after, there are also some limitations in reflecting on this history and comparing it to our current state. So, influenza and coronavirus come from 2 different families of viruses in which we've experienced multiple pandemics of influenza strains in recent history, as I just briefly went over, but only epidemics of coronavirus in 2003 and 2009 until our current pandemic was declared on March 11th of 2020. So this is relatively new territory, and it's difficult to predict if coronavirus of this magnitude will play out the same way that we've seen other influenza pandemics unfold. However, there are some commonalities like modes of transmission, symptoms, and vaccine availability. And we can potentially utilize these similarities when making informed decisions about the future. So I wanted to look more into the trends of a respiratory disease with characteristics similar to that of COVID-19 within North Suffolk. And the good news is that we have a fair amount of data from both COVID and influenza cases in North Suffolk specifically. So this is a graph that I put together after running a report for COVID and influenza cases in Maven beginning in 2016 to February 5th of 2022. Influenza is indicated by this blue line and COVID by this orange line. Influenza counts can be read on the left y-axis, and COVID counts can be read on the right y-axis. The main question that I asked myself when creating this graph was, what does seasonal influenza look like in North Suffolk compared to COVID-19? So there are some key takeaway points that I just want to focus on. So the first being that COVID peaks during the past 2 winters have been during the first week of January. And my thoughts on this is that these peaks are probably highly influenced by human behavior throughout the holidays specifically, and that we're seeing those impacts about a week after that holiday, those holidays. Secondly, influenza peaks are hitting sooner compared to the prior year for the past 6 years, with the exception of the flu season of 2020 into 2021. Also that this trend started prior to the introduction of COVID. So if we look here, influenza peaks in 2016 hit during mid to late March. And then in 2017, the peak hits about mid to late February. 2018, about early to mid-February, 2019, early February, and then in 2020, we have about late January, and then moving into that 2021 flu season, we're seeing it hit late December. And so the public health nurse of Chelsea, when I shared this with her, her name is Paula, and she made a very astute observation mentioning that this could possibly be because flu vaccines are initiated earlier and earlier. And so by the time that wave hits, that immunity is already waning from those immunizations. So lastly, I want to point out that there's this alignment with the COVID and flu peaks during this past winter. Now, will this overlap continue to happen? I don't know. I don't know if this winter wave will continue to trend this way with this overlap of influenza and COVID-19. There's a ton of moving variables at play, but during this past winter, that at least seems to be the case. Okay, so what does an endemic COVID-19 look like? This has been a very colorful conversation the past couple of months and becoming more prevalent around the dialogue surrounding COVID-19. Now that we know how other respiratory disease pandemics have played out in the past and what trends of seasonal respiratory disease looks like in our community, we can now ask what the future of COVID-19 looks like. If COVID looks anything like the flu, it technically won't be endemic, but rather a manageable, predictable seasonal influx. Endemic diseases are rare, especially respiratory ones with characteristics similar to that of COVID-19. Some of these endemic diseases include malaria and chickenpox and cholera. Measles are also now endemic since the introduction of vaccines. However, outbreaks can interrupt this endemic state of measles. So people often refer to influenza as endemic, but I don't necessarily think that's true. Influenza typically reaches a seasonal epidemic threshold every year. And so what does this mean? What's a seasonal epidemic threshold? So this is a quote from a CDC spokesperson stating that an epidemic threshold refers to the point at which the observed proportion of deaths is significantly higher than would be expected at that time of the year in the absence of substantial influenza and now COVID-related mortality. So this is a graph provided by the CDC demonstrating pneumonia, influenza, and COVID-19 mortality nationally from late 2017 to early 2022. Now, the number of flu deaths are here in yellow, right here, starting in 2018. And then we also have the number of COVID deaths, which are here in blue. Now, this wavy black line is the seasonal baseline, and the epidemic threshold is on top of that. So the second wavy black line. Now, in 2018, 2019, and a bit of 2020, we see that red line slightly surpasses the epidemic threshold, indicating a seasonal epidemic, because that percent of deaths due to PIC, which is pneumonia, influenza, and COVID-19, surpasses that epidemic threshold. So then when COVID-19 is introduced, we see that percentage of deaths due to PIC, it shoots up, and it hasn't come back close to epidemic threshold since. While the flu isn't classified as an endemic virus, it does have an expected seasonal epidemic, and there's a level of predictability to it, and measures put in place to reduce the spread, like the flu vaccine. So if influenza trends are similar to the future of COVID-19, reaching that epidemic threshold point closer to baseline may not be instantaneous or even obvious, especially since we know that death rates tend to lag after cases. And so Also, declaring these certain levels of disease, like moving from a global pandemic to a seasonal epidemic or an endemic disease even, are more at the discretion of global organizations like the World Health Organization or federal levels like the CDC. So how do we prepare for whatever is next, whether that's a continued pandemic or even a seasonal epidemic? Can we place ourselves in a better position than we were before? And how can our response be improved for the next wave? So there are many unknowns from the past 2 years, but there are some knowns that I think we should hold close, the Swiss cheese model being one of them. We know that how COVID-19 spreads, and we know how to combat it to mitigate risk. First, there's this level of personal responsibility, which is here on the white slices of Swiss cheese, which includes things like social distancing and PPE adherence and hygiene. And we have these shared responsibilities, like contact tracing or messaging or isolation and quarantine guidance. And we also have vaccines, free, accessible, and safe vaccines. And so we've learned, especially with the Omicron variant, that vaccines are less effective with preventing transmission, but highly effective in protecting individuals against severe disease, including hospitalization and death. And so we have these tools. How do we implement these tools in an appropriate, timely, and evidence-based fashion that best protects our communities? So on February 25th of 2022, the CDC released a revised framework for recommended use of counties across the US. The director of the CDC, Dr. Walensky, was quoted here explaining her reasoning for this new layered strategy, prevention strategy, stating, "We want to give people a break from things like masking when our levels are low, and then have the ability to reach for them again should things get worse in the future. We need to be prepared, and we need to be ready for whatever comes next." So as I mentioned, these are new community level metrics provided by the CDC. And so just to go back to what the old CDC metrics are, is that they highlighted transmission. And so these 2020 metrics highlighted transmission by quantifying the total new cases per 100,000 persons in the past 7 days, as well as the percentage of NAATs, which are the PCR tests that are positive during the past 7 days. So if we look here in the top right corner, based on those quantitative metrics, we then are placed into the categories of low, moderate, substantial, or high transmission levels. And then there's subsequent guidance or recommendations provided by the CDC for a community based on what levels they're put in. So these 2022 metrics includes a bit more than just transmission, although transmission is the leading indicator. So based on transmission of total new cases per 100,000 persons in the past 7 days, that being the leading indicator, you're then put into these kind of two categories of whether fewer than 200 cases or 200 or more. And then based on that transmission level, then metrics are looked at like severity, new COVID-19 admissions per 100,000 population, a 7-day total. And just highlighting that that's anyone with COVID-19 diagnosis who is admitted to the hospital. So whether you entered for or with COVID, so if you're an incidental case or not, you are still considered a strain on the system and therefore counted in this metrics. In addition, we also have a metrics that highlights the burden on the healthcare system. So the percent of staffed inpatient beds occupied by COVID-19 patients. So if we move to this framework, which is on the lower left-hand corner of the slide, we start with the leading indicator of transmission, so fewer or more than 200 cases. And then based on that, you have levels of severity and burden on the healthcare system. And if you're interested in learning more about this and this framework, certain precautions that can be taken, or in mitigating risks that are recommended by the CDC, you can also visit the link here, and there's more information on that. So in accordance with this framework, I wanted to look at new cases of COVID-19 in North Suffolk over the course of the pandemic and include this 200 new cases per 100,000 threshold indicated by this red dashed line here at the bottom. And so during the winter waves, the past 2 winters, it looks like we're kind of almost automatically put into that more reactive state, since we have 200 or more cases, and therefore we would have, if this framework was put into practice, bypass this low level and then automatically put into a medium or high category for transmission, meaning that more stringent preventative measures would then be put in place. And so like I mentioned, it almost seems like during the past 2 winters, we would have been put into this more reactive protective state because we would have surpassed that threshold. All right, so the current state of affairs with a framework like this, and this is provided by the CDC, where they quantify these different metrics for each county throughout the US. As we can see, majority of counties in the US are in the low category, so the green category. And all of the counties in Massachusetts are currently in the green as well, meaning that we have low COVID-19 community levels. So that is my presentation, and I'm happy to take any questions, comments, or feedback.
Anybody has any questions?
No, I don't, but that was very well presented.
Yeah, thank you so much, Anne Marie, for the beautiful presentation. Very informative. Thank you so much.
You're welcome. I will pass this along to Lauren, and she can pass it along to you all.
Thanks again.
Copies of the slides. Yep, no problem.
At this time, we will be voting on regulations of the keeping of the chickens with all the revisions that were done last month.
Yep, so in front of you are the revised regulations. All the changes that we made from last month are included in this copy, and if I can answer any questions, if you have any questions about the changes, I can answer them, but they were all discussed last month.
I do not have any questions. Dr. Costanza?
Nope, I don't. I'm all set.
So we're going to proceed with the voting with Dr. Costanza?
We voting yes?
Yeah, I vote yes as well.
Great, so we'll have you sign the copy that we need to, for all of our official stuff, and then we officially have regulations for the keeping of chickens in Revere.
Also, we'll be voting tonight for keeping the bees.
So if I can jump in. So we are adding, whenever we need to, we're going to add a new section onto our Board of Health meetings, which is when there are licenses that apply to the Board of Health, we're going to present the board with our recommendations as the Public Health and Inspectional Department in terms of if we think you should be approving a license, if there's any issues, we'll go through all of those things as they come up each month. This month, we actually only have one license that we are going to be presenting to you all, and it happens to be our first beekeeping license application. This was submitted by Damian DeMarco. He submitted to CitizenServe his application on November 5th, 2021. We, as the Inspectional and Public Health Department, inspected his backyard bee hives on March 16th. He is in compliance with all the regulations that were promulgated by you all as the Board of Health. And so we recommend that you approve his license. It is a yearly license, so he will be renewing next March as well if he chooses to. But yeah, if you have any questions, I can answer. But we believe that we recommend that you approve his license for beekeeping.
Yes, I'm gonna go ahead and approve that for the bee license.
I second, I approve.
Great, so we'll also have you sign the form for that, and we will process and send him his license after today's meeting. Thank you.
Thank you, everyone, for attending this meeting. Motion adjourned. Good night.